I am so honored to introduce you my favorite doctor in the whole entire universe, Dr. Andrea Moreira. Dr. Andrea Moreira is a board certified plastic surgeon who specializes in the use of advanced technology in breast reconstruction. She now serves as the director of Reconstruction program at the Allegheny Health Network, the Division of Plastic Surgery. She received her medical degree from the University of Para Medical School in Brazil. She completed her residency in general surgery at the Cleveland Clinic. I actually had the honor of meeting Dr. Moreira in 2012, December, I believe it was, or 2011, December, where I was recently diagnosed, well, at that time diagnosed with breast cancer, stage 2. This lady changed my world. She changed something inside of me to take this horrible diagnosis and transfer it into something positive. So without further ado, I introduce you to my superhero, Dr. Moreira. Thank you for joining us.
Thank you so much. I'm so excited about this invitation. I'm so honored to be here to talk to you on a topic that, it's so dear to me. I was so excited when you actually sent me a message about your sister circle. I think it's just an amazing thing that you're doing for the community and so much needed. Yes. And I cannot thank you enough for letting me take care of you when you did it. Very good. All right. So my plan for today is to give an overview of breast reconstruction. I'm assuming that most women who are going to be watching this either went through it or going through it or have a family member that they can relate. And I'm sure they all have questions about what can be done after this kind of diagnosis. So I'm going to start from a long time ago. And oh, God, this needs to move. Okay. These are my disclosures. And I always think that breast reconstruction is a very personal decision. I cannot stress this enough because there's so many options, and patients really have to figure it out what's good for them, not for a family member, not for the doctor. It's their decision that they're going to have to live with for the rest of their lives. And the other thing I always like to say is that it's fluid. You might not want something now, but maybe later on, if you decide, you can have options available. Um, and some patients just decide to go flat, and that's a big movement going on right now. And that's perfectly fine. It's all what's going to make sense on their heads, pretty much. If you look at the number of new diagnoses around the country, and I put the numbers at Pennsylvania because that's what I am right now. So you see in 2020, they estimated 12,000 new cancers diagnosed. Those are just initial diagnoses. So you can pretty much put a number similar to that to every state. So the number of women diagnosed with breast cancer every year is quite high. And we know, based on the report of the American Society of Plastic Surgery, that probably half of that number will undergo some sort of reconstruction. Um, and when you look at the patients undergoing their own tissue, the number is still quite small compared to the patients who undergo implant reconstruction or just kind of a rearrangement of the breast, like a breast reduction. But if you look at the history of breast cancer, I think it's really interesting that the first time somebody mentioned about it, it was by the Egyptians a long time ago. And this was called a coagulum of black bile. So you imagine the stage at that point. And the way they treated it was they just chop it off. So it is just crazy to see that something like that happened. But then you look at the 1800s and Dr. Housestead began doing his first mastectomies. Those are very aggressive procedures. They took not only the breast, but they also took all the innervation, all the lymph nodes, and all the muscles. So these were operations to treat cancer, but they were also extremely aggressive for the patients, and sometimes they did have a lot of problems with that. So I like to say that we came a long way since Dr. Housestead procedure that left that kind of a deformity in most patients in lymphedema and all that, to the development of clinical trials that showed that radical mastectomy was not really necessary for most patients because it did not improve their survival, to the development of nipple-sparing mastectomies. And I'm very proud to say this was actually begun at the Cleveland Clinic by Dr. Crow, and to what we have right now, that we reconstruct breast and we're able to resensate that in a way that the patients look normal and they feel normal about themselves. And that's the whole goal on breast reconstruction. I'm going to talk a little bit about the process because I think it's really interesting and you don't realize when you're going through the motions, but I see the other side. So I think I want to show my perspective on how things go. Um, Usually when you see the breast surgeon, they will say, well, if you're interested in reconstruction, I might refer you to see a plastic surgeon. So when they come to see me, I usually tell my patients, you're there to gather information. There's too much. I don't expect for you to make any decisions because it's just impossible. So those appointments are quite long. I try to offer them everything that I know it's available. I do have my little information package that gives information on implants, on different techniques. I like to give web resources because there's some that are actually quite good, um, and education media. And many times I show pictures so patients kind of have a better understanding of what to expect with the procedure they're choosing. I like to talk to my patients on how to be healthy for surgery. I know we don't pay too much attention to this, but I actually do because I think it's really important. And there are things that we know can improve how you recover from your surgery and how you heal from surgery. There is a really good website at the American College of Surgeons that talks about it. It's called Strong for Surgery. It kind of give you little notes of what to do to improve any kind of surgery that you go through. And I can say some things here that are really important for breast surgery. One is stop smoking, control of comorbidities such as diabetes, um, you know, um, put yourself in an exercise routine. I'm not talking about extraneous exercise, but just enough to keep your heart and lungs in good condition. And I always like to do a nutrition evaluation for my patients. I think the overall nutrition assessment, it's really important. And you will be surprised how many patients after surgery, everybody brings them food. And it's all comfort food and it's delicious, but it's not good for healing because it's all carbohydrate based. So I think if I give them an overview of what to do before and immediately after surgery, maybe I'll give them a better chance to heal without any problems. So I think this is really important. And the other thing, my patients come and say, I don't care what I'm going to look after surgery. I just want the cancer out. I tell them to really not listen to themselves so much because once you're healed from the cancer and the cancer is out, you are going to worry about how you look because it is a perception of your personality and how you feel about yourself. So there's more than just getting the cancer out. Um, so I think it's very important to make everybody understand that. And and you don't, many patients don't understand that from the beginning, but they will after, because they want to go back to what they were before. They want to feel whole again. And sometimes reconstruction really matters for them. So I try to understand what's the patient's goal. They want to look natural. Do they want to look better than what they are? Do they want to look the same and not have their body image affected too much, or they want to get a tummy tuck? And all of this are reasonable. And my goal as a plastic surgeon is really to minimize disfigurement, and that's all. When I discuss with my patients, I like to talk about all the possible options. I usually take measurements and take photos, and I like to point out what is the ideal that they want and what's I can actually do. I think if we all have a good understanding from the beginning, satisfaction is higher for sure. And we know there are three step concepts for breast reconstruction. Um, every breast is different. Can't try to make the same for everyone. That doesn't really happen that way. Every breast has a different footprint on the chest wall. They have a different projection or volume, and the skin that overlies that breast varies. Some women they have very tight skin, some women have very loose skin. You can't get the same kind of results on both. They will be different. Um, so I think for every plastic surgeon, if you understand all this three-step concept, then you can be very successful in breast reconstruction. Now, I want to mention which patients I don't think are candidate for immediate reconstruction, meaning reconstruction that's done at the same time of the mastectomy. Number one, those are the smokers, because we know that's about 30% chance of having complications after uncontrolled diabetes, because diabetes makes your healing pretty much unpredictable. So I usually send my patients to primary care. Oh my God, it keeps going. Primary care so they can be evaluated. Patients with very severe comorbidities, heart disease, long-term use of steroids, or patients who cannot fully understand what we're doing, or patients who have lack of support, because you will need support if you are planning to undergo reconstruction. Now, it's a teamwork. What I do just works well because we have a good relationship with the breast surgeons. I'm sure Sherry knows this lady, and she's an amazing breast surgeon. So we usually discuss with the breast oncologist surgeons, because we want to make sure that whatever we do it safely and we do what's right for the patient. So communication is a key on that situation. Then I'm going to talk about different kinds of reconstruction. I'm going to start with implant-based reconstruction, because about 70% of the women in US, that's what they get. And that can be done in a two-stage, which is very traditional. You place a spacer inside of the breast pocket at the initial surgery. You expand that spacer until you have a volume that the patient is happy with. You take the patient back to surgery, take that spacer out, and put a new implant in there. Or you can do a one stage reconstruction, meaning that instead of putting a spacer, you go straight to a breast implant. And there are benefits for both techniques, and there are indications for both techniques. So the tissue expanders, they look like this. They have a metal port that I can access using a magnet, so I can add fluid to it. They have a shape that it's not exactly the same shape of a breast implant, but allows most of the expansion to happen in the lower pole of the breast, because that's what we want. A two-stage reconstruction using a tissue expander, it is more uncomfortable for patients for sure, because it feels really hard. They have to come to see a plastic surgeon more often, because they have to expand that area, and there is 100% chance of a second operation, because you need to remove that expander and put a real implant in there. Now, when you do a direct to implants, people call it breast in a day, because when you leave the surgery, you already leave the OR with your reconstruction completed. So there's no need for more visits or expansions and all that. And you can possibly avoid a second surgery. Sometimes we still do a second procedure for cosmetic touch ups with direct to implant. Um, implant-based reconstruction evolved throughout the years. Before, we used to put an implant completely under the muscle, and sometimes these would ride up. So women over time, the implant is right here, and they're super uncomfortable. Then we moved to a partial muscle coverage. That's how we called. And now most of us try to avoid touching the muscle whatsoever. We tend to put implants on top of the muscle. There is no right or wrong, but there are benefits of one technique versus another. When you place an implant under the muscle, you can still have a wonderful result, but every time the patients contract the chest, you will see this kind of um, changes. And that's because the muscle heals stuck to the skin. There's no breast tissue in the middle. And we call that animation deformity. So many women don't really like that. The other thing I can see sometimes with implants under the muscle is that patients sometimes do have higher incidence of pain. Um, they might be fine and then they go to their yard, work like crazy, and they come home and they have all these pains. And of course, they're worried about what could be going on. And most of the time, it's just the muscle contracting over that implant. Now, when we place an implant completely on top of the muscle, patients tend to recover a little bit faster. They do have less pain. The disadvantage is that sometimes that implant is palpable because there's nothing to protect. So patients have what we call rippling. And many times I have to bring my patients back to surgery, add fat all over to be able to create a result like that. This is a patient who did not have cancer. She was BRCA positive, and she ended up having an implant-based reconstruction and fat grafting after. Now, when I plan for surgery for my patients, I like to take several measurements, and they will help me to choose what kind of implant I'm going to use. And there are different types. Implants can have the same volume, and one can be wider and less projected. The other one can be super narrow and high projected. It all depends on the breast base. And that's how we choose an implant versus another. I always like to have a tissue expander just in case if I can't put an implant, I know I have a backup plan. And in the day of surgery, and this is quite new, I think most centers are doing it right now, but we have all this protocol to improve pain after surgery. And that's called ERAS, so Enhanced Recovery After Surgery. And the main goal for this is to reduce pain, nausea, and vomiting. It also to expedite recovery. So there's a series of medications that we give before surgery. Then we have our anesthesiologists to do a anesthesia local block to reduce the pain after surgery. And there is a series of medications that we prescribe after surgery. The whole goal is to prevent overuse of opioids. I do discuss with my patients and the breast surgeon the location for the incisions, and that can vary a lot. Sometimes they tell me, oh, I need to do an incision right here because the cancer is right there and I need to get to that. Sometimes they will tell me it's okay to go under the breast and leave all the skin behind. If the breast is too large, sometimes I do the same incisions as a breast reduction. So it all depends and it varies from patient to patient. But one thing I can tell you, if I can avoid that transverse incision as much as I can, I will, because I think it's easier to get a better cosmetic outcome if you don't use that incision. Sometimes it's not possible, but we try. And sorry, there will be some surgical pictures. I hope nobody's like too shocked, but I wanted to show the process. This is that same patient that I showed in the beginning. So the breasts were removed through an incision underneath the breast. I use a balloon to decide what size implant to use. Then I would wrap that implant on a mesh and placed inside of the breast using this fancy pastry bag that I wish I had invented. And this is how the patients look immediately after surgery. Everything looks lumpy, bumpy, and all that. But once they heal, you know, they tend to look quite normal. Um, After surgery, as I said, I like to manage expectations because it never looks right. And it does take time for everything to settle. Um, Patients would have glue or tape over their incisions. I do use a specific dressing around the drain. I can tell you, patients absolutely hate the drains. I hate the drains, but they need to be there. um, and there are several things that we ask them to be aware, to watch the breast, to make sure there is no redness or no swelling that's out of proportion. I do send my patients to occupational therapy once the drains are out. We want to make sure that the arms are moving, particularly if they had lymph nodes removed. And of course, we wait at least 3 to 6 months, and if we need any kind of revision. Just to show another patient, this is a patient that maybe in some centers they would say no reconstruction because she had advanced disease, but she was, I want reconstruction. I don't want to be without the breasts. So we did it. On this side, we had to remove the nipple because the cancer was around that side. The other side, we did not have to. And we went straight to implant. And this is the patient after radiation. She did quite well. And she was very happy. You see some discoloration from the radiation, but over time, I'm hoping a lot of that kind of gets better. But she has a good shape. She can do her things without feeling, you know, uh, unsure about herself. So every time we place implants, I always like to discuss with my patients the possibility of using fat in a second procedure. Do they all need it? No. And we can talk about it. It's a totally elective procedure if they do. So, adding fat on top of an implant will decrease rippling. So, patients, when they look at the patient, they won't see that little funny wave. It helps to increase the volume. And if there was radiation given, it kind of helps to improve that radiation changes. Now, there are disadvantages to it, and patients need to know is that not all the fat that we inject survives, and there is a risk that few areas can die and make into oil cysts, and that's about 10 to 12%. And I can tell you that can make patients very stressed out because you did all this operation to get rid of the cancer, and out of the blue you feel something on your chest. So that tends to lead to second look ultrasound and sometimes biopsies. I know this sounds horrendous, but the benefits of fat grafting and reconstruction, they're real, and it does look a lot more natural when we do it. The way we do it, we collect the fat using a syringe. I'm not going to play these movies because they're kind of gross. And then we decant the fat and we re-inject to create volume for the breast. Ah, there we go. Ah. And that's what I'm talking about. This is the rippling that the patients don't really like, and you can fix that with fat grafting. Now, this is what I had to talk about implant-based reconstruction. There is a lot more, but that was mostly to give an overview. Now, I'm going to talk a little bit about reconstruction using the patient's own soft tissue. And I'm going to mostly focus on the deep flaps because it is the most common flap that we use to reconstruct the breasts. We can collect tissue from many different areas of the body, but this is pretty much our workhorse, is the deep flap. Um, and usually I like to say that the deep is not the same as a tram flap. A tram flap, which was described a long time ago, takes the whole muscle and moves everything at once to reconstruct the breast. And it's not a free flap, it's a pedicle flap. The deep flap, you know, leaves the muscle behind. So it creates less problems to the abdominal wall. So what we usually do, we mark the excess of fat from the belly button down, and we make an incision that goes from hip to hip. It's the same incision that we would do for a tummy tuck. And we map the blood vessels that are feeding all that skin and fat. These vessels, they run under the muscle. So when we harvest that tissue, we find exactly where they are, and we just kind of separate the muscle at that location and fish the blood vessels from underneath without cutting and dividing the muscle too much. And then that tissue is transferred to the chest and reconnected to blood vessels on the chest wall. So, and you wonder, why do women undergo this such a giant operation to reconstruct the breast? As I said, it's a personal decision. It's the patient's own tissue. So it's softer, it's more natural, tends to match the contralateral breast a little bit better. And over time, it's less surgery because implants you do have to exchange every 10 to 15 years. You can get rid of some of the excess tissue on the lower abdomen. Patients are happy, for that. And also, after radiation therapy, sometimes is the only way you can reconstruct the breast. Um, and patients usually ask me, what's a patient that's a good candidate for a reconstruction with their own tissue? It's individually based. Ideal health patients with excess abdominal tissue, well controlled diabetes and non-smokers. Um, and you might not be a good candidate if you're too thin due to the lack of extra abdominal tissue. So there are other options for that. Patients who underwent surgeries in the past, patients who are extremely overweight because of the risk for wound healing complications, as well as I keep saying smokers and diabetes because those are the two things that I find it really can affect your healing. For very thin patients, it's still possible to offer a deep flap, but many times we have to make changes to make it work. Sometimes we have to do what we call the stacked flaps. We do two flaps on one to reconstruct the breast. Or we do what we call the extended deeps, that we go all the way to the flank area to get rid of some of the excess tissue. And if none of that is available, we can still harvest tissue from the buttock, inner thigh, and other places if that's really what the patient wants. Now, I'm going to show a few slides of how the procedure is done. So bear with me. I'm sorry if it's too visual. But usually we get a special CAT scan before surgery, and that helps us to see exactly where those blood vessels are, in relation to the skin and fat. And as you can see here, you can pretty much visualize the whole blood vessel and those little perforators right there feeding the skin and fat. And we also expose vessels on the chest wall so we can reconnect them. We try to optimize our patients. We do get preoperative clearance. We do the ERAS protocol that I told you to control pain. They undergo surgery. From there, they do go to the ICU in my hospital. At the clinic, they don't. Then they go to a regular nursing floor after. And because it's a free tissue transfer, most of the surgery, we are either wearing loops or we are under the microscope to put those blood vessels together. This is just to exemplify a patient. This lady had a right breast cancer. She had a lumpectomy, no radiation, and she recurred. So she underwent preoperative chemo. And at that point, she decided to have bilateral mastectomies. On this breast, we did have to take skin because some of that was affected. For the other side, she had the nipple and just a little bit of skin removed from the lower breast. As you can see here, we map the blood vessels. We separate that tissue completely from the belly, as you can see here, and we lift only based on the blood vessels, and we reconnect two blood vessels on the chest wall. And this is the patient immediately after surgery. And this is her, after nipple reconstruction. And because we had to remove some skin, she needed a skin paddle on that side of the breast. Another patient, this lady had a unilateral reconstruction and she had a nipple reconstruction after. If you look at her before and after surgery, her breasts look very similar, and that's what we want to achieve. Another lady who had bilateral nipple sparing mastectomies, were able to save the nipple and aureola on both sides. And this is she after her deep flap reconstruction. This is another lady. She had only a right breast cancer, so she had a right mastectomy, and I ended up doing a reduction in the other side. And this is her before and after surgery. We're able to save her nipple and everything. So in general, the results tend to be quite good. Another lady, she underwent bilateral deep flaps. She had a lot of tissue removed, as you can see here. And I did not cover those nipples because those are actually reconstructed nipples. And I wanted you to see some of the results can be absolutely amazing after, the reconstruction of the nipples. And that's pretty much what I usually do. When I do their own tissue, I call the three-legged man, and I kind of put all of that together to create the nipple projection and use some of the skin around to create the areola. So that's how it looks at the end. And once it's all healed, patients can undergo nipple areola tattooing. Um, of course, we can't stop. We keep thinking about better ways to improve the surgery. One of the new things that I am working on, and I'm being very excited about it, is to use the robot on the deep flaps. Robotic surgery has been very common for urology, pediatrics, general surgery. But for plastics, it doesn't make too much sense because we're always taking a lot of tissue, so it's not really minimally invasive. For the deep flap, is different because we still have to make an incision in the muscle, and we still have to go and find those blood vessels. So if we can minimize the incision that we make inside to harvest the vessels, we think we can have less postoperative pain. We can ask our patients will recover faster. Maybe we can disrupt less of the muscles, and we have a less incidence of bulges and hernias. So what we do, instead of making that big incision that you saw on the beginning, we actually just make a tiny little incision. And most of the surgery is done using the robot inside of the belly. So we take the blood vessel completely through that little tiny incision. So patients tend to have a faster recovery for sure with this procedure. And just to show a patient, this lady failed implant reconstruction, so she came to see me, and we ended up using her own tissue. She had a bilateral deeps, and we did with the use of the robot. This is her result 2 weeks after surgery. She still has a little bit of the skin from her belly underneath, and we'll get rid of that later on. So for our patients, when they have their own tissue, I like to tell them that it's going to feel like a truck passed over your body. And it really does. It's a lot of surgery. It's a lot of commitment from the beginning. When I like to explain for patients that when they choose implants, is instant gratification. over time, satisfaction tends to drop a little because of the need for implant exchanges and things like that. When you use your own tissue, satisfaction on the beginning is low and increases over time because patients tend to feel more normal and they always score higher on quality of life questionnaires. Um, so it is something, that it's to consider. So patients stay in the hospital anything from 3 to 5 days. And it really takes about 8 to 12 weeks for full recovery after a deep flap, for sure. When they go home, I tell them not to wear a bra for about 2 weeks. They will get a binder. No core exercises for about 8 weeks. I do like to refer to physical therapy because I think it's important. And if there is any revision needed, usually 3 to 6 months after surgery. Now, the last thing that I want to talk about, and I'm not sure if I'm over. Oh, am I over time? I think I am. Oh, okay. It's about breast sensation. I'm not sure if you guys are familiar with this article at the New York Times a few years ago. It was like front page talking about breast reconstruction and lack of sensation. We know we can reconstruct breasts and make them look quite nice, but if there is no sensation, you know, we're so glad that this came to life and brought to our attention an issue that we did not pay as much attention before. Partly because there's a dogma that it doesn't work, partly because we never thought was that important, to tell you the truth. But the truth is, it is very important. When patients have some sensation on the breast, they don't get burns, they don't hurt themselves because they can feel it. And if you can get nipple areola sensation, I think it's the cherry on the top of the ice cream, and that's the most difficult thing to achieve. But I think it's important that we are working on it. I think most surgeons are still on baby steps on how to make that work. I'm very happy to be part of a group of physicians who is working on it. And we can just keep going. Yeah. So one thing we've been talking about is that you can actually preserve a lot of these nerves after a mastectomy if you pay attention. And the sensation to the breast comes from the intercostal branches that they come all the way from your spine, and they kind of pierce the muscle just lateral on your chest. And they have several branches. The one who really feeds the nipple, gives sensation to the nipple, is a fourth intercostal nerve, and that usually branches in two. One branch comes through the breast tissue, and this is consistently removed with the mastectomy. The other one is superficial. So I would say about 25% of the patients, if you pay attention, you can save that. And there is also a little nerve that feeds the medial aspect of the breast. Most of the time, this is preserved, and most women do have sensation on the medial portion of the breast. We know about 10 to 30% of women will recover some sensation, but we want to see if we can improve that. So, a nerve sparing mastectomy would be a mastectomy that, where the breast surgeon aims to save some of these nerves. And what I want to show you here, this is this white cord here. This is a little intercostal nerve going straight to the breast tissue, as you can see. But sometimes it goes to the breast skin. This is a patient who had the breast removed already. This is a pectoralis muscle. This is her lateral chest wall. And you can see here the nerves completely preserved. So I know she's going to get a better sensation of her breast over time. So this is something that we're trying to teach. And I'm hoping over time we'll see more of that after a mastectomy. preserving the nerves. You see here the breast surgeon holding the breast tissue, and she dissected out the nerve from the breast tissue. I connected with a piece of a nerve graft, and I connect that to the nipple. This is the patient's nipple seen from inside. It takes a long time. It takes 1 millimeter a day for these nerves to grow. But this is all we have. It's baby steps. And hopefully, if we all work together as a group, we'll have better, outcomes for our patients. Um, I think this is, has a great potential to be sensational. If we can get those nerves to work the way we want it, you know, eh, for the patients, like going back, almost back to what they were before. But we still have a lot of work to do. We're working with insurances to get approval for the grafts because sometimes they don't want to pay. And there are several answers that we don't have, several questions that we don't have good answers quite yet, but we're working on it. I think that's pretty much what I wanted to talk about. I want to thank you, Sherry, for inviting me. I hope this is not too boring, but that's pretty much my speech to my patients when I see them. And I thought it would be easier to understand that way. I hope it's not too graphic either.
No, I think it was perfect. And I remember when, I met with you and Dr. Fanny. Dr. Fanny told me, Sherry, don't do a whole bunch of research on Google, but I needed to do it to figure out what was the best route. So I'm grateful that you provided this very graphic introduction overview so that our sisters can make the better decision for us. So thank you. Perfect. I trust you wholeheartedly. And this was phenomenal.
Yeah.
I'm so glad. I'm so glad. There's so much on Google,
Mhm.
and sometimes it's scary. Once in a while, I go and I do some research to see what I find. It's a little bit of everything. There's good information, but there is
Mhm.
also,
Yeah.
yeah.
And to me, I'm sorry, it's a Shamar, one of Sherry's friends. It was actually interesting to me because I work in post-op, pre-op and post-op. So just to see, what actually goes on in the OR, from that aspect and that it, helps women. It was very interesting.
Yeah. So sometimes I do have, some, especially radiation nurses or visiting nurses and post-op nurses to come to the OR to see, because it's very difficult, I think, to give information or to give advice for the patients. Oh my God, here comes the monster, my dog. if if you don't see what goes on in the OR. I'm glad this is good for you, Shamar.
I had a question for you, Dr. Moreira.
Yeah.
My question for you, well, first of all, I just want to say you gave a lot of information, some information that I wouldn't even consider, like the loss of sensation. But the two questions that I would like for you to answer is one, could anybody do anything like before surgery, or would you recommend them doing something to prep for surgery to make healing better? And also the second question is, what would be situations where you would absolutely not recommend a mastectomy, reconstruction after mastectomy?
Yeah. So there are several things that can be done before surgery. I think if you walk half an hour a day, every 2 to 3 days, you improve your heart and lung capacity. So that helps you to recover. And we also know it improves your muscle mass, which helps on your recovery. Multivitamin. I usually tell my patients to take vitamin C and A because those help with the healing process. Um, I tell them to eat protein, and it's amazing. You actually have to do an effort to eat the amount of protein that you need a day, because you think, oh, it's easy. I don't think it's easy. Like if I have to eat 80 grams of protein a day in if you look at one piece of chicken breast is 20 grams. So it's nothing compared to the amount that you actually have to eat to make up your necessities. So I tell my patients to do actually an effort to count the protein intake and eat it. And I tell them to decrease sugars because it's pro-inflammatory no matter what. But those are things that I ask them to do. If patients have diseases that need to be addressed, for example, thyroid problems, high blood pressure, the diet, the sugar control, it's a big issue. I tell them to optimize all of that as much as they can before surgery. Um, those are things that are important. Now, patients that I would say it's probably a no for reconstruction doesn't mean that it cannot be done delayed, but at the time of the mastectomy, patients who have very advanced disease with inflammatory breast cancer that involves all the skin, we tend to recommend delayed reconstruction for sure. That's number one. Patients who have severe heart disease, uncontrolled diabetes. I saw a patient in the other day, her blood sugars, her hemoglobin H1C in average was 13. The normal is 6. And she was taking steroids and she had a heart transplant. So probably not the healthiest patient to undergo surgery. Sometimes I talk to the patients that if they underwent chemotherapy before surgery and they were really sick from the chemo, that we get blood tests and they are anemic, or we look at the protein level is low and they just don't look too healthy. Sometimes I tell them, how about we do that later? Because those are things that increase the chances for problems and you really don't want to do that. Yeah. And those are your two questions, right? Yeah.
Yes, thank you. That was so helpful. I think that was some very great information, especially things to do before surgery.
Yeah. I think it's important. We have to prepare ourselves no matter what kind of procedure we do.
Dr. Moreira, is there anything that can be done to reduce the scarring tissue after surgeries?
Yeah, that's a big question. So everybody heals different, Sherry.
Mhm.
There are people who healed perfectly fine. There are people who develop keloids or thick scars or discolored scars. Sometimes if I look at a scar that they had before, that gives me an idea. It's almost like a predictor of what can happen later, right? We know there are groups of patients that tend to heal more than what we would like. We know that Black patients tend to form more keloids or thick scars, as well as the red-haired and the Asians. So those are three groups that I tend to counsel a little bit more. I think the most effective thing that I see for scars is to use silicone sheets. You usually start about a month after surgery and you keep that on every day, take it off to shower, put it back on for about 3 to 6 months. I like to follow my patients because if I see that the scar is getting a little thick, sometimes I do add some steroids and I do steroids injections. I find, particularly with breast surgery, it's easy to notice thick scars close to the middle here and on the lateral. Um, and I tend to look more for those areas, but silicone sheets, steroid injections, sometimes I do re-excise and close and add steroids at the edges of the incisions. If the situation is really bad, that I don't know if I can fix only with, what I have available, I actually discuss with some of the radiation oncologists, and we come up with a plan to excise it, and the patients go in the same day and have a localized dose of radiation therapy for the keloids, and that tends to help. I had a patient that I saw, which is, I think it's sad because she came for a second opinion. She had her surgery someplace else, and she did not have cancer. She was high risk, and she had large breasts. And I'm not sure exactly what went in the mind of her surgeon, but she was a Black patient, and he made an incision above the nipple and an incision that way. And she keloids the whole thing. I mean, it took me a while to help. She needed we had actually have to send her for radiation. Um, and that shows you the difference in care from where you go. But that was tough. But again, I try to make sure that we're on top of it. I think the best way to take care of scars is to be aware of them and act when they're still young, that you can actually do something about it. Yeah.
Makes sense. Makes sense. Mary or Fran, do you have any questions?
This is Fran. I went through a preventive bilateral on November 2nd, and I chose to go with a flat closure with no reconstruction. But at some point I'll need to say that was successful and I'm happy with the results. But my question would be, how long do you really wait to see? And I saw some of your slides said 3 to 4 months or 3 to 6 months till you can really tell if you've received or that you've achieved the results you were hoping for. Because if I'm not happy, I would go see a plastic surgeon. But how long do I wait? That's one thing I'm just having trouble trying to grasp my head around. Like, when do I make that call? Like, yes, I'm happy, or no, you know what, I need some plastic surgery.
So I would say wait for at least 6 months. And I'm going to tell you why. Our body goes through phases of healing. In the initial phase, we call that inflammatory phase, and it takes about 3 months. So that's when you have swelling, the tissues are beginning to heal, there are new blood vessels being formed, and there's a lot of inflammation, right? In between 3 and 6 months, your body goes through a remodeling phase. So a lot of the swelling subsides, the skin gets a little tighter, and you can actually start seeing your final result. Now, on that phase too, between 3 and 6 months, that when you start to notice 6 thick scars or keloid formation. So one thing that I would recommend, since you had a flat closure, go on Amazon. You can go, like, I say Amazon because I feel like you can buy your life on Amazon, and you can buy silicone gel sheets and apply to your incision lines, and do that consistently because that will help your scars. But I would not do anything for that. I would wait 6 months.
Okay, that is very helpful, because I was having difficulty getting any sort of timeline from doctors or anything. So that's very helpful. And so what you said though was for the silicone sheets is like that last phase, that 3 to 6 months is when to start applying those.
I would start now.
Okay.
The sooner you do it, the better. So the silicone sheets, they come on a package, and what you need, and it's almost like a sticker. One side has a little bit of a glue to it. So you cut just enough to cover the scar. You don't need to put a big sheet. You just cover the scar. Those sheets are reusable. So you have to take it off to shower, pat dry the area, dry the silicone sheet, and put it back in position. And you can reuse it for a long time.
Okay, excellent. Thank you so much. That's very
You're
helpful.
welcome.
Mary, did you have any questions?
Yes, I have a question. I'm not quite sure how to state this, but I'm curious to know the longest delay of someone that you have done reconstruction, the surgery on.
A patient who did not have initial reconstruction and chose to come back later.
Someone who had a mastectomy but chose years later to see what the options are, and you may have gone ahead and done the surgery.
About 10 years. You can wait. It's, you know, once you have your mastectomy, because that's pretty much the pressing surgery, right? Or lumpectomy. You can wait as much as you can. You know, there is no time. There's no time frame.
Okay,
Yeah,
thank you.
you're welcome.
So Dr. Moreira, so when you did my procedure, and actually I have my friend NECA and Shamar, she doesn't have her video on, but you see NECA has on burgundy today, not pink.
Oh,
Hi, Dr. Maria.
oh, is she on?
Look how pink on, Sherry.
Look at that.
And I love October. I love breast cancer month. Be quiet, Sherry. Sherry want to laugh at me anyway. The visual slides, they help. They were informative. So I always tend to ask Sherry from time to time. Still back to that day, because we laugh at it. And I'm going to say it. I had on all the pink. I was very be quiet, Sherry.
Yes, had a pink flower in her hair. And what she's speaking of is I had my surgery, my 14-hour surgery, which is what I want to ask you a question about, Dr. Moreira. But my friends came to the emergency room. Well, they came into recovery, and I was still dazed. But I think I woke up out of my daze when I saw my friend coming in with all pink.
They're all pink. They're all pink. I remember that. I loved it. And I said, I can't, you guys are all here for her, and you all have your outfit. It was awesome.
I think it was just me. I was going to ask you that.
Did you have the full outfit that you wore that day?
Yeah, it was a full pink jogging suit. And
Yeah.
I had on breast cancer jewelry.
Yeah.
I don't care. I needed everything with me. I was in shock. I was in pain. You know, it was a first. It for her to say it didn't run through her family. It was a hitter. It really hit hard when you hear that someone that you love, you care about. You know, I didn't know what to do. Like, let me just pull everything. Let me get everything and take it there. So, you know, for support and just to calm me. Because I've had a few people in my family. My grandmother passed.
Oh, you muted.
She wanted to pass at home. Her daughter, my aunt, I think I spoke to her just recently. She had was it breast as well, and she had to get a similar surgery. So it really hit home again when Sherry announced it. You just would never think. You would never think.
It's
and those
closer
visuals help.
than where we think.
Yeah. Your immediate, group that you hang around, you hear it, you see it on TV or from another family or friends, associates, but never like your immediate group. I did a few walks prior to Sherry announcing that, breast cancer walks, just out and about, just going to support, not thinking of my grandmother, my aunt. It was so head on with a lot of different people and announcing it through, TV and other aspects. It really hit home. And that was my way of showing my support for Sherry to continue.
It was an amazing way. Yeah, you are so positive. Yeah.
And I'll do it again, Sherry.
Yeah, I think I almost popped a stitch trying to laugh at you,
What's Shonda, man?
Yeah, was
day.
supposed to be on. Yeah, that was
To
funny.
this day, I don't care. Laugh, laugh, laugh. I'll do it again, but hopefully that never happens again.
Exactly.
Pray and I pray. I was just actually sharing the other day. Again, those visual effects, they really helped because I always tend to ask her from time to time, how does she feel about it to this day? Like what she see as of right now. I haven't asked her, I was like, Sherry, will you can I see them? I want to see how they look. I didn't get an answer. I think we were talking about so many different things.
I showed you. I would show anybody. I've shown a lot of people, Dr. Moreira.
You showed me back in the day, like early.
Yes, we've definitely seen them.
Yeah,
Yeah.
everybody's seen them.
So that means that you do good work, great work, Dr.
Yeah,
Moreira.
but she's always talking about you.
Oh,
She's always
thank
talking
you.
about you, doctor. So I'm like, Sherry, how I look now? Because it's been years.
Yeah, look at nipple. I need to go back for tattooing, but I think out of
Yes, you
all the
said it.
surgeries, the tattooing was the worst. So I will pass on the tattooing.
You know, some people say that it actually hurts.
Yes, that
The
was very.
tattoo.
No, it's a good thing.
Yeah, it is. But geez.
Well, thank you, Dr. Moreira. Thank you.
Oh my
thank you.
God, my
Appreciate it.
pleasure. I'm so happy to be here talking to you and look at you guys. It's so
Yes,
wonderful.
indeed.
Excuse my attire now. Coming in
Yeah,
from outside.
you should
My
have
hair
had
is
on
a
peace.
mess.
Should have had on peace. But
My
Dr.
hair is a
Moreira,
mess.
so my procedure was 14 hours. You partnered with Dr. Fanning on it. How did you do it?
I
That
don't-
was my biggest fear. You were going to fall asleep.
I don't know.
Wow.
I don't know. Somebody asked me, I think, you know, those people when the adrenaline goes high and they just keep going.
Mhm.
I think it's the same.
Okay.
I don't know. I got so wired on these surgeries.
Wow.
Yeah.
Wow.
It-
Yeah.
It's interesting. Yeah. Sometimes I get home and I was like, how did I do this?
Yeah. Yeah.
But I think you just go when you're so focused.
Yeah.
I know we all have things that when we do, we can just keep going.
Mhm.
Yes. And it's God. That's what keeps us going.
Mhm.
And he operates through you. He's
I
there.
have
So
to say, I'll bring him with me to the OR every single time.
that's it.
I
Mhm.
do.
Yes.
Well, thank God for you and your gift to help people,
Yes.
and,
Oh,
and
Thank
also for being here. We appreciate you.
When Sherry said you would be on, I said, "Oh, it's a girl. She's gonna be on there one day." And I was fashionably late. I didn't put it in my calendar. I said I will remember, and I keep telling myself I need to use my calendar on my phone. That's one of my to-dos. I apologize.
You're fine. You're here.
so
That's
glad
what
to
matters.
see you, though. You're here. That's all that matters.
Thank you.
Yeah, and the last question for you, Dr. Moreira, for anyone who is considering any type of breast reconstruction with you, how do they get in touch with you?
Okay, so I have to give you my office number. Just let me get it, because I can't even remember my own cell phone number. Sorry.
And this is Shamar. Do you do surgeries on people if it's not related to breast cancer?
I do. I do mostly body contouring. Sometimes because of the breast cancer, it gets so busy. And sometimes I have to delay cases they're not, more
That-
pressing.
Yeah.
That's
Yeah.
But yes,
understandable.
I do all kinds of surgery. I just don't do a lot of faces. That's not for me. Okay, but I do breast reductions, augmentations, tummy tucks, and all of the liposuction.
And me and Shonda, at the time, me and Shonda were talking about removing the fat from our fupas and putting on back in the back. And we have to go
You
do
don't
the
need
back
any help
part,
with that.
don't you?
No, she's not taking you as a client. Thank you. I said, I'm just kidding. I'm just kidding. You don't need any help back there, Nectar.
Mute nectar.
Oh my God. All right,
But
so
I do
let
have
me
to
give
tell
you
you.
my work phone if somebody gets in
Right.
contact with me. It's 412 578-1808 and 412-715-5378. But even if somebody just wants an opinion, or if if they want a person that they can go to in Cleveland, Cleveland is really dear to I love my partners at the clinic. If there's anything if somebody has a question and who they should see, just let me know.
Will do, definitely. One last comment before I let you go. Well, we're talking about I wanted to go to a C, but you were encouraging me to go down to a B. But I didn't want to go down to a B. But I will say now that I wish I would have went down to a B because they grew back. So I'm now back at a double D.
It's funny, isn't it?
Yes.
It's funny because time, our body changes so much over time. Yeah.
Yes, indeed.
Are you happy with the double Ds?
No, I'm not. I'll be calling your office.
Call my office. Let's reduce it a little. Oh my God, this dog.
You can't find any pretty bras or anything. So I want C's again. Or maybe I'll do the B's. But Dr. Moreira, it's been truly an honor. I'm so happy to see you. I'm glad you're doing well. Thank you for everything, your gift. You changed my life. And I hope that this announcement or this recording will help you to get get more opportunities to change other people's lives like you have done mine. So I really appreciate you. I love you dearly. And thank you so much.
Me too. Thank you. It was my pleasure. This was a treat. It was a treat.
Indeed.
Just seeing you and seeing your smile. Oh my God.
Right.
So, been attacked.
Yes, wants your attention. All right. Take care and thank you again. Thank you.
Thank you.
A wonderful Sunday and a wonderful end of the year, ladies.
Yes, to you.
Thank you for hosting. This has been wonderful. Thank you so much for the invite.
Yes, thanks, Fran. Have a great day, ladies.
Bye. You too.
Bye.
Thank you.